Okay, hi guys, how's it going? Last lecture of virology block. Starting off today talking about rabies virus. So, very famous virus. What? Oh, no, I didn't just say that, did I? No. So, this is a virus that we've all heard about. It unfortunately is not eradicated, it's still circulating. We get cases in the United States. It belongs to a big family of negative sense RNA viruses enveloped called the Rhabdoviridae. And that's a family of this larger order of Lissa viruses. I only mention that because Lissa means like angry, and rhabdo is from the Latin rabere, which means to rage. So like madness, rage, all kind of lend themselves to the name of this virus. It kind of gives you a hint as to the presentation. This is a classic example of a neurotropic virus. So when you get it, even though it may not initially be in nerve tissue, it will migrate towards the brain and spinal cord and ultimately cause this fatal disease known as classic or, classic rabies. In the United States, this is a problem that we control mostly by vaccinating domestic pets. So if you go outside of the country, and you've been to a country where they don't have robust rabies vaccination programs for their dogs and cats, their rabies incidence rates can be much, much higher. And also the percentage of rabies cases caused by dog bites and cat bites is much higher. Here, most of our transmissions occur from these wild animals. So you can see this bar graph on the left-hand side. Raccoons, followed by skunks, bats are considered to be a major reservoir species for transmission in the United States, foxes. But those are the most common animals who get rabies, but it's definitely not impossible for other animals like cows and deer and lots and lots of other animals to get this disease. Basically, like any mammal can get rabies and spread it. In terms of transmission, the virus itself mostly concentrates in the salivary glands. So while it might be affecting the brain, the transmission is through saliva. For animals, they have this biting behavior. The aggression that comes with rabies causes them to bite, and then with their saliva, they have a concentrated amount of this virus in it, so they can transmit really efficiently. For humans, when we get infected, usually by animal bites, we go ahead and have the same presentation, so this virus will concentrate in our saliva as well. But when we get aggressive, we usually, as a species, don't bite. We're not really good biters. So, most of us. So transmission is really poor from human to humans, and we're usually considered dead-end hosts for this virus. Okay, in terms of pathogenesis, this is an important slide to understand, so there's a lot of detail on here. In this figure, it's good, but it's not super high res, but it does do a good job of explaining pathogenesis of rabies, fulminant rabies. So you get an animal bite, usually somewhere on the legs or on their arms and forearms. And at that initial site of injury, that virus will start to replicate very slowly and very poorly and inefficiently in the muscle tissue around that site. Eventually, that virus is going to make its way towards the peripheral nerves in that area. And then, once it hits the peripheral nerves, it hitches a ride retrograde along those peripheral nerves slowly, hitching right on dynein, this motor protein, all the way until it makes its way to the spinal cord. Once it gets to the spinal cord, then it continues to ascend up to the brain, and there you get these like classic rabies symptoms. This is an important step in the outcome of the disease, because if you can treat it, and there are some treatments we'll discuss, before it reaches the CNS, the outcome is usually successful. You can stop progression to rabies. But if the virus hits your CNS, that is game over. That is irreversible, and treatments are considered to be almost invariably unsuccessful. So what happens when it reaches the CNS? It is a neurotropic virus, so it likes neurons, and it replicates very quickly at that point. So once it hits the CNS, you do not last much longer. We may do it another week or so, sometimes a bit longer. But virus will start replicating to high levels, they will start being shed into primarily saliva, but sometimes like tears as well, perhaps. Sometimes a little bit into the skin, but it's mostly concentrated into the salivary glands. And then over the course of that symptomatic period, as your symptoms progress, you will start getting what we would call rabies furiosa. For most patients, about 80% of patients have rabies furiosa, which is characterized by the classic aggressive behavior, the bizarre behavior, hallucinations, and then some of these symptoms that are real symptoms. This is not like a mythological thing. The hydrophobia, the fear of water, it's not really a fear of water, but it's a response, a spasming of the throat muscles when you come into contact with water, because it is kind of like a painful just response to the idea of drinking water. So patients can be thirsty and they still have this extreme hydrophobic reaction when they're offered water. Aerophobia, similarly, that's a test in some countries where they don't have a lot of good diagnostic capabilities. They'll literally waft or fan a patient, and the air that goes over their face will cause them to flinch because it causes the same sort of spasming response with reflux in patients. So aerophobia, the hydrophobia, the hypersalivation, that's mostly going to characterize the rabies furiosa, furious rabies. About 20% of patients will have the paralytic form or dumb rabies, where they slowly start losing control of their muscles, bladder and bowel control is lost. But in either one of these forms, ultimately the patients will become paralyzed, become unable to breathe on their own, they'll lapse into a coma, and they'll die. Going back to this slide, another point here to make is the rate of progression of this virus, particularly at the bite site as it's making its way towards the site of injury, I should say, site of entry, as it's making its way towards the CNS. This is clocked at a certain rate, so 50 to 100 millimeters per day. So that has implications for how long you can anticipate that patient will have preventable disease, like the life-saving interventions. If you get bitten on the toe and you're like super tall, you have some time before that rabies virus travels up into your CNS. But if you want to bite, like a bite on the neck, on the face, the survival time is considered to be much shorter, and the window for intervention is much shorter as well. I do have a couple videos I want to show you guys just real quick. I hate my slideshows, but hang on 1 second, bear with me. Let YouTube teach. There's some narration on this, but you know what, we don't necessarily need it. This link is in your notes as well, so you can watch this video. But what we're seeing here is a young child in a country that's considered endemic for rabies, and basically the only thing you're really watching for in this video is the reaction when the mothers offer the child some water. This is that hydrophobia that I was talking about, where the child is like flinching and probably having painful spasms at just like the thought of coming into contact with this water. There's some weird theories as to why hydrophobia and aerophobia have evolved as symptoms, like, you know, the virus wouldn't want to be diluted out with water, so you can't drink. I don't know how proven those theories are, but those are some of the prevailing thoughts about why you have that response. And then in animals, I don't think I'll go full screen on this, but rabid animals, kind of erratic behavior right there, jerking, erratic motions, extremely forward behavior, coming up to people where they should normally have a fear response. Anybody ever seen a rabid animal before? A couple people? What kind of animals did you guys see? Coyotes? Rabbits? Yeah. So, anyway, that's what it looks like in humans and in some animals as well. Really sad disease. As people go into rabies furiosa, the clinical rabies, it is, even though they have a lot of neurological problems that get progressively worse, they still have moments and long periods of lucid thought where they're entirely aware of what's going on, and they know they're gonna die. The type of care they get varies a lot. Like in the developing world, that care shifts mostly to palliative care by family members. People usually have to be restrained for the last couple days of their life so they don't injure other people. In the US, we have a much different way of taking care of people. We put them oftentimes in life support in discussion with their families. And there have been some really high profile protocols that have been conducted on patients to try and actually save their life after you've progressed to clinical rabies. But those protocols are extremely controversial and variable and usually have not worked in a way that we can count on or rely upon. Anybody heard of the Milwaukee Protocol? No? Okay, well that was done in Milwaukee, Wisconsin in 2005 with a girl who was 15 years old. She had rabies, and it was from a scratch from an animal that was rabid, so they didn't really think much of it and progressed to clinical rabies, CNS rabies, without HRIG or vaccine that we're going to talk about. So they induced a coma in her and gave her some non-specific antivirals, like molnupiravir and another generic antiviral med. And they induced a coma with the hope, basically, of just slowing her metabolic activity and allowing her own immune system to get under control. She did pull through, and I suppose clear the virus with her own immune system, but that is, like, again, that's considered a one-off. So when people say it's 100% fatal, you know, they pretty much mean that it's 100% fatal. Yeah. Say again? I don't know. It might have been. Okay, I think that was everything I wanted to cover on the presentation itself. In terms of diagnosis, a pretty good number of cases are diagnosed at autopsy because it is fatal and doesn't always have a clear presentation. So if you detect viral antigen in brain tissue by doing a direct fluorescence assay or some other immunoassay, that's a really good, sensitive, specific test, but of course you're using brain tissue. While the person is still alive and rabies is suspected, we have a couple other diagnostic options. The virus is shed in tears and in some cases in the skin. So if you take a skin snip, particularly in the back of the neck, right there, you might be able to find some virus if the person is already symptomatic. But those are the common sources, the CSF, saliva, and skin biopsies for PCR and antigen detection. All right, talking about what you do when you do have exposure to rabies through an animal that is behaving erratically or aggressively. The first thing that is oftentimes overlooked is washing the bite site thoroughly for like 15 minutes, very rigorous washing. Because the hope is that you can actually, since the virus isn't going to be taken up into circulation and rapidly circulated around the body, that you can actually rinse out most of the virus from the bite site. After that, whether or not you administer just the immunoglobulin and the vaccine, or just the vaccine by itself, depends on whether or not that patient has been vaccinated previously. If they have been previously vaccinated and they're sure that they've been previously vaccinated, they only get the vaccine and they don't get the HRIG. So remember when we were talking in block 1 about passive vaccination or passive immunization? That's what HRIG is. It's a human rabies virus immunoglobulin that you can give people. The rabies vaccine itself, when it's given prophylactically, like I'm sure many of you probably had the rabies vaccine before, if you're deployed out to countries where it's endemic, that is a 4-course vaccine, you give the initial shot and then you repeat on days 3, 7, and 14. And then you generate some antibodies, which should be protective. So if you get exposed, again, like that, you should only need HRIG after that. With the HRIG itself, you administer it only once at the beginning of the prophylaxis to people who are not vaccinated. It's important to not use the same syringe or use the same anatomical site as the first vaccine dose. Any ideas why that might be recommended so strongly? Yeah. Second. Yeah, and importantly, you don't want to interfere with any kind of ability to generate an immune response at that site. So you do it at a different anatomical site so that you do not interfere with any existing immune responses going on at that site. But yeah. You have up until a week after administering that first dose of the vaccine. And after that time, the vaccine itself is either going to generate an antibody response or it isn't. So seven days afterwards is that window for you to actually provide HRIG. And there are recommended dosages according to body weight, but that's generally the guidance for post-exposure prophylaxis. All right, so moving on to the last bit of the deck here. We have a couple viruses that cause rashes and warts to talk about. The first one, human papillomavirus, is the virus that's associated with a lot of the warts that are on people. Most of these are benign warts. The medical term is verruca, and HPV is extremely common. Most people at some point in their life will have HPV infections, and as I said, most of these are going to be benign warts. Common warts, plantar warts on your feet. The ones we worry about are the high-risk types of human papillomavirus. These are the ones that can be oncogenic and are associated with a bunch of different cancers, but a lot of them are reproductive cancers like cervical cancer. In terms of the virology, this is a small capsid double-stranded DNA virus, and that's important for its ability to cause cancers. How it gets into the skin is usually through breaks in the skin. So oftentimes people get this virus, like if you're barefoot doing karate or you're doing gymnastics or things like that, you're barefoot, you have a little break in the skin, the virus can get in and infect the basal keratinocytes that are still alive and actively replicating. Most of the low-risk types of HPV are then going to infect those basal keratinocytes but not integrate into the host genome. So when the basal keratinocytes divide and differentiate into cells in the stratum spinosum, for example, the virus itself is amplifying its own genome that way. So it's not really like a lytic infection, but that's how it amplifies after that initial infection. And then when it spreads, it doesn't even need to kill or lyse the host cell because those outer layers of the skin just slough off. So it's like a desquamation and it's totally natural. What causes the actual wart itself is the fact that the virus can suppress some of the normal cell cycle checkpoints. So you get a proliferation of those infected cells. And because of that, you get this like characteristic hyperplasia, usually benign in those affected cells and only in those affected cells. So the region that grows up is well defined, well delineated. You don't have like this spreading presentation. It's just like a well-defined wart that develops there. In terms of the high-risk types of HPV that can affect people, what happens with these is they do oftentimes integrate into the host genome. And there are a couple genes in the HPV genome. Like right here, we're showing on the left, we're seeing a schematic for the genome for one of those high-risk types, HPV16. There, in red, there are two genes that are highlighted, these oncogenic genes, HPV16. So you see E7 and E6, they both have different functions, but they're kept in check. When they integrate into the host genome though, oftentimes the regulatory proteins that keep them from being expressed are disrupted. So you start getting expression of E6 and E7. E6 will bind to this tumor suppressor gene called P53, and that will contribute to proliferation. And then E7 will bind to this P105RB, this is the retinoblastoma gene, which also has tumor suppressing activities. So the combination of E6 and E7 together causes those infected cells to basically become immortalized and start dividing without any kind of apoptosis that you would normally have for epithelial cells. In terms of the cancers that are associated with these high-risk serotypes of HPV, serotypes are listed at the very bottom, like 6, 11, 16, 18, etc. The original vaccine that we developed against HPV for the high-risk oncogenic serotypes had only 6 serotypes in there. I've listed 9 of them. So the 2006 one was the original Gardasil vaccine. It's been updated, so now we covered 9 different serotypes, high-risk serotypes of HPV. And this has done a lot to contribute to reducing the rates of cancer deaths due to HPV. In particular, you can see the graph on the bottom there. The types of cancer that are associated with HPV, 91% of cervical cancers are attributed to HPV infections. So by having this vaccine provided and available to the population, preferably at a young age before they become sexually active, you can prevent them from picking up this virus, and you can prevent, like many of these forms of cancers are considered to be vaccine preventable forms of cancer. So it's really important that we get make that vaccine available to as many people as possible. Going back to cervical cancer, I don't think it's any longer the second leading cause of cancer deaths anymore because we have really aggressive screening, we have pap smears, and the vaccine itself. So that ranking has probably dropped now below lung cancer and some other types of cancer, pancreatic cancer and some other cancers. But still, all of these cancers are considerable and vaccine preventable if they're caused by HPV. Moving on to a completely different type of virus, we're talking about the coronaviruses again. We've actually talked about some members of the coronavirus family already when we were talking about Hep A virus, if you remember talking about Hep A, this fecal oral transmission virus. That is a coronavirus. And also when we were talking about rhinoviruses, that respiratory virus that causes mostly like coryza symptoms. You guys know what coryza means? Anybody heard of that word before? Coryza. Okay, so coryza is basically where you have a bunch of nasal inflammation. So runny nose, postnasal drip, congestion, it's all coryza. Unfortunately, with rhinovirus, that's mostly limited by the tropism of the virus to the upper respiratory tract like that. So it's a coronavirus, HIV is a coronavirus, but some of these other coronaviruses are more associated with a lot of nerve diseases like poliovirus, and as well as some rash diseases like Coxsackie A virus. We'll talk about those briefly, but lots of different members in a variety of different presentations. For transmission, since these are capsid non-enveloped viruses, fecal oral transmission is considered to be a main route. If the virus causes a rash, like Coxsackie A virus, hand, foot, and mouth disease, for example, you can also transmit it through contact with vesicle secretions in those, in the rash itself. And it can also be transmitted through respiratory secretions as well. Talk about Coxsackie viruses, there are 2 major types, Coxsackie A and Coxsackie B. Coxsackie A causes hand, foot, and mouth disease, which is a widespread rash that develops all over the body. Here you can see on the top, this picture is showing herpingina, where you have the rash inside the mouth, inside the oral cavity. And then it quickly spreads all over the body. So within a day or so, you start seeing it on the palms. This is sort of a low resolution photo there, but in the middle, that's showing the fingers with a characteristic vesicle from hand, foot, and mouth disease. This is really hard to discern, but here at the bottom, if I just point her up, this is on the soles of the feet. You can see the rash presented on the soles of the feet like that. There is a seasonality to Coxsackie A virus. The classic time of year where we start seeing hand, foot, and mouth cases is usually right around this time of year, end of summer into early fall. We see most cases for Coxsackie A. Coxsackie B, which I remember with this very simple mnemonic B for body, tends to cause some pretty serious infections. Two main presentations. One is when the virus gets into circulation after initial exposure and goes to the heart, and it has tropism for cardiocytes, so it causes direct damage to heart tissue. And as a result, you can get myocardial symptoms or pericardial symptoms. So either the muscle tissue around the heart or the sac that covers the heart itself can be affected by Coxsackie B viruses. The presentation, if the heart is infected like that, these symptoms that can be common to all sorts of problems affecting the heart, the cyanosis, the gluing of the skin, you can't oxygenate the blood properly, the heart isn't working, the tachycardia when you don't have enough pressure that's being generated to keep the blood circulating, so you're compensating by a faster heartbeat, and then the enlarged heart and even the enlarged spleen is characteristic for those myocarditis and pericarditis infections. This has also been attributed to the cause of sudden death in infants who are infected with Coxsackie B. So if an infant dies of a heart failure suddenly, Coxsackie B is considered to be a common cause of that. Another presentation is called pleurodynia, aka the devil's grip, because it is extremely painful and it mostly affects the muscles in the diaphragm and the intercostal muscles in between the ribs. So every time a patient inhales, it causes sharp, stabbing, knife-like pain that is just excruciating for that patient. That will usually last a week or two, but the pain is so severe that is associated with things like vomiting after these fits. It's just a very painful condition to have. So those are the specific presentations for Coxsackie A and Coxsackie B, but they are both able to cause encephalitis, so that is, and meningitis, a cause of aseptic meningitis. So both of these viruses are oftentimes included on PCR panels where you're testing CSF for common agents of meningitis and encephalitis. Yeah.
Is either one of these more prevalent in children versus adults? I feel like I hear hand, foot, and mouth more with kids than I hear in adults.
I think it is more prevalent in children.
Is there reasons for that one? Like, depending, like, is it A, more children-oriented than these?
Yeah, so in terms of transmission, I think there are a couple of reasons. One is immune-related. Kids probably don't have the same immune system. There's no vaccine for it. And then in terms of transmission, it's transmitted through like respiratory droplets, for example. And kids, the way they behave when they're together, sound like an anthropologist describing them, but they have like very, they transmit viruses very easily based on their behavior and not washing their hands. The best way to prevent hand, foot, and mouth disease, since there isn't a vaccine, is to wash your hands all the time.
But adults can't get it.
Oh yeah, adults can definitely get it. Adults can definitely get both Coxsackie A and Coxsackie B. In fact, this is from a recent outbreak that affected young adults of military relevance. So this was just pulled from my usual source, AFHSD, but it was at West Point last fall, which is, by the way, kind of right peak in season for hand, foot, and mouth disease, right? In September, there was a pocket of cases in, however old cadets are, late 20s, maybe early 20s, late teens, young people who were crowded together. And 46 cases of hand, foot, and mouth disease were identified in that cadet population with an exposure cohort of over 4,000 cadets. So most of these are going to be pretty minor. Most of them are diagnosed just based on presentation, although you can definitively diagnose with PCR. But one guy was hospitalized for eczema coxsackium rash. You can see that right there. Eczema coxsackium rash. Another E. coli virus is of note is enterovirus D68. If you remember way back to the beginning of this step when we were talking about respiratory pathogens, enterovirus D68 was on that list. And it was up there, we had it on that slide that had the seasonality, if this is ringing any bells, hopefully, and that really weird biannual case surge. So usually we get most cases of enterovirus D68 in an even number of years. So right now we're in an off year for enterovirus D68. same sort of seasonal peak, I wish I could expand this. On the lower left, you see a graph from 2022 that shows the cases of enterovirus T68 just in that 1 year, and they are peaking right around August timeframe. So we're coming into that season. Most of the cases of enterovirus T68 result in just normal common cold symptoms. That's why it's included as a common cold virus. So runny nose, a little bit of headache, not that much of a big deal, maybe a small fever, and cough. Sometimes you might get a little bit of these more unusual symptoms, even with the milder infections, like a skin rash, mouth blisters, little ulcers in the mouth, and body and muscle aches isn't particularly unusual, but the mouth blisters and the rash is. That's not uncommon for enteroviruses, but what is unique to enterovirus D68 is its ability to progress to a really severe paralytic presentation called acute flaccid myelitis, which ranges anywhere from like a mild tingling, like a little bit of disorder and dysfunction of the nerve cells, all the way up to a full paralysis that can be life-threatening. So they say it's polio-like. That doesn't mean it's less severe than polio. It means it's similar in that it causes that kind of flaccid paralysis. And some of the early signs and symptoms are you can see people who have a harder time swallowing. They might start slurring their speech, their eyelids start drooping, things like that. This does overwhelmingly affect children. And when we were doing routine surveillance, this virus was known about, but it wasn't particularly on the radar until we had a bad outbreak epidemic year in 2014. So just a little over 10 years ago, there was a pocket of cases of kids getting AFM, and we don't have very good tests. We don't have very good treatments for this virus. So because of that, we've really increased the amount of surveillance and tried to educate providers on looking out for signs and symptoms of enterovirus D68, not because of the respiratory problems, but because of the more severe AFM issues that can occur in a relatively small percentage of the pediatric population. Yeah.
Does that go?
Yeah, it should. I think if you get it, like it can kill people if it causes severe paralysis, but it's not like a chronic infection. Again, like the fact that there is no specific treatment is always problematic, and when people do have paralysis, the best they can offer is doing physical therapy and occupational therapy as those damaged tissues recover. And then we have full, real deal poliovirus. This is another very, very famous virus. As of the coronavirus, it does replicate in the GI tract, but you don't really associate it with diarrheal symptoms. It's more associated with CNS symptoms. And the vast majority of people who, I should say more like were infected with polio because it's not circulating much anymore, very little. And the vast majority of people, 95%, they were asymptomatic and they were able to clear the virus. Some people, this virus would, from circulation, start infecting muscle cells, and you get some muscular deterioration. So you get occasionally like 5% of the infected population with muscular deterioration symptoms. But then fewer than 1% of people would go on to have some sort of paralytic myelitis. And this paralytic myelitis was devastating, but it depended on, once this virus, which was able to cross the blood-brain barrier, those few cases, reached the brain, it was neurotropic also, so it would be destroying motor neurons. And the type of paralysis that a patient would have would depend on which motor neurons were destroyed by the poliovirus that got into the brain. So as a result, you could have some people with paralysis of the limbs, some people with paralysis that made it difficult for them to swallow and eat, and then some people who had paralysis of the respiratory muscles, so they actually could not breathe on their own. In that latter category, that damage was permanent, so they would never be able to recover the ability to breathe on their own. And before we had the vaccine for poliovirus, the only solution to keep these people alive was basically to put them in these huge contraptions called iron lungs, like mechanical ventilators before we had modern mechanical ventilators, but that would allow them to survive and breathe on their own. And they would spend their entire lives in those iron lungs. For people who had paralysis of the extremities, like FDR, Franklin Roosevelt, had poliovirus and contracted it when he was 39 years old, and he was an adult. He lost the use of his legs so he was in a wheelchair for much of the remaining part of his life, or used leg braces to walk. But in photos of him later in life, where he's like at the beach or in a swimming suit or whatever, you can see how much his legs had atrophied over the years. So yeah, that was very, very common before we developed the vaccine for poliovirus. We developed two vaccines, both by very famous American scientists, Sabin and Salk. And they came out within 5 years of each other. The first one that came out was the inactivated poliovirus injection that stimulated an IgG response. That was the Salk vaccine. And that had a profound effect from this peak of poliovirus cases that we had in the 40s and 50s. And then about 5 years later, the Sabin vaccine came out. That was the oral vaccine. With the oral vaccine, the OPV, oral poliovirus vaccine, that was a live attenuated viral vaccine. I shouldn't say it was, it's present tense, it's still used today. So with this live virus vaccine, the problem with live virus vaccines like this is that occasionally they can revert back to wild type phenotype and cause actual disease itself. So that is the problem we have today. You can see this map at the bottom here that's kind of capturing the current picture of where we are with poliovirus globally. Don't have it in the US anymore, so not here. But in countries like Afghanistan and Pakistan, we still have naturally occurring wild type poliovirus transmission. I think this map is from 2022, it's really hard to see, but you can see in red there with Pakistan and Afghanistan, some naturally occurring poliovirus transmission, right there, red dots. And then throughout Africa, you see a bunch of green dots and orange dots. Those are the circulating vaccine-derived poliovirus cases that have occurred that year. So just due to the vaccine itself, the OPV oral vaccine. The reason why some countries still vaccinate with OPV is because it's much more affordable than the IPV vaccine. The World Health Organization has been trying to make it easier, more affordable to transition to that inactivated vaccines to prevent the CDD-PD cases. I did pull, just for this lecture, a more updated map. I think this is last year's data for poliovirus. But it's similar presentation from what we saw the year previous. You still see only primarily Afghanistan and Pakistan for natural transmission of wild type, and you still see cases of vaccine-related poliovirus in these countries that use OPV vaccinations. Let's go ahead and take a 10-minute break now, and we'll pick up on measles virus.
This whole row. I think they've heard. Like he can get up, walk his way down to the car, like that, side door, and that was my first interaction. Let me shake his hand.
The timing's got to be very good, and that's very
Or is it come in, mess you up? What I mean is like years later.
Yeah.
We assume, yeah, it just gets in, comes in, messes you up, and then and it's just. I forgot his name, but the same thing with William Desmond. He's one of the first ones to, they put him on a stage. The first one to transition.
Gotta do the mustache. You gotta walk it out.
Oh, yeah. Oh my god. I'm gonna put a box for you.
It's called Free. Ironic. Really good.
And the actors.
Andrew Garfield. Yeah, the guy from and he's sitting there, he's like, go down.
Alright, so, sorry, they just told me Hulk Hogan died, so I'm super distracted now. I know, now the whole class can be distracted.
Ozzy Osbourne.
No, Hulk Hogan, the wrestler.
Yeah, so did Ozzy Osbourne.
I said,
No, so did Ozzy.
what?
Yeah.
What?
Ozzy Osbourne died.
Oh my,
I'm sure we're done. I was looking forward to that. We're done.
no,
yeah, brother.
no, we're gonna collect results from the drive. I seriously consider
No, he's not dead. Brock said so. Brock said he's not dead. No.
So it's hard to let it go. Just let it go. Alright.
Oh my god. Okay. We're gonna drive on with the remaining slides. Oh wow. Alright, measles virus. It's hard to compete with those deaths, but this is, I mean, if you're gonna have a virus do it, it's gonna be measles virus. Super interesting virus, especially this year, right? You guys have been following banner year for measles virus. I do want to point out there's a huge mistake I made on this slide down here with the deaths per year. I meant cases, so if you would please correct that on your slide. And then in terms of deaths, particularly since we do have, oh sorry, I can't see that, it's between 1 to 200 cases per year. And that's in the US, not deaths. We might get 1, 2, or 3 fatalities a year because we have that huge herd immunity in the United States, 95% of the population is vaccinated, et cetera. So do make that correction. But that said, it has still been a really remarkable year, and I wanna talk about what's going on with that, that outbreak, slow burning outbreak that we've had for months now in the US. First, though, a little bit of basic virology about this virus. It's a paramyxovirus, so it's a, in a negative sense, unsegmented RNA virus enveloped. It is a respiratory virus, but it also causes rash as well. So it's transmitted primarily through inhalation of these respiratory droplets that contain the virus. You guys remember that little chart we looked up that had severity versus transmissibility on it? You guys remember where measles was for susceptible populations? At the tippy top with an R naught between 12 to 18 people, so it's extraordinarily infectious, airborne contamination, which is impressive for an envelope virus, but when somebody's shedding this virus and they leave a room, that virus remains in the air for hours afterwards. So it affects a lot of people. In households where one member is infected, the likelihood of infecting others that are unvaccinated is extremely high, it's like 90-95%. Very, very likely to transmit. And for people who are unvaccinated who get the disease, or even if they are vaccinated, may still unfortunately possibly get the disease. The presentation is you're usually going to get symptoms. So all of these diseases that I've been talking about where it's possible to get subclinical or asymptomatic disease, that usually doesn't happen with measles. It can be mild, but you're gonna get a presentation usually. This is also considered a childhood disease, even though adults absolutely can get it. It's one of those childhood rashes, the childhood exanthems, sometimes called first disease because it's the first one to hit. Another nickname is rubeola. It's been called rubeola for a long time. But typically, once you get exposure to this virus, you inhale it, it starts replicating, you get some viremia. And then some of the first symptoms are respiratory symptoms, cough, the rhinitis, runny nose, fever, conjunctivitis. And then you will start getting some more distinctive symptoms that are unique for measles in this presentation. One of those are Koplik spots. See on the top picture that I just popped up, these kind of like white spots that appear in the oral cavity. That's oftentimes considered to be pathognomonic for measles virus, but there's a little bit of controversy about that. Also distinctive is this macropapular rash that appears on a person within a couple days after exposure. That will start at the hairline, but after those respiratory symptoms usually. That rash will usually start around the hairline and then suddenly start going downwards and then spreading all the way out so it covers all the extremities. In this picture of this child with a rash, you can see how thick that rash is. This baby is definitely not smiling, definitely not happy. In terms of transmission, the contagious period, this is good to know. They're talking about when you start shedding virus relative to when symptoms start appearing. So you get your initial exposure, you have a little bit of a incubation period where you're not shedding, not symptomatic, but then you could start shedding 4 days before you start getting those respiratory symptoms and 4 days before you get any of these other symptoms like your rash, for example. And then D+4, that's after symptoms resolve, they're still shedding virus. So that contagious window is important to know. 4 days before symptoms, 4 days after symptoms. The secondary complications that are associated with measles are important to note. One of those significant secondary complications is that you can get bacterial infections oftentimes. This is another one of those viruses that has been implicated in CNS infections, so it can cause aseptic meningitis as well. One of the most significant problems associated with measles, and the reason why it's so important to stop transmission, is because of this immune suppression though. A lot of your immune system is devoted to clearing this virus, and because of that you deplete a lot of your immune cells, and you get this kind of immune amnesia that can last for weeks or months and sometimes years. When you're like a 2-year-old or a 3-year-old child, that's not a good time in your life to have reduced immune system functions. Your maternal antibodies are waning and you really need to be developing your own immune system. So the fact that this is associated with immune suppression is a really important thing to prevent. That's a strong reason to vaccinate the population by itself. In terms of the vaccine, there's a slide that talks a little bit more about it, but it's the MMR vaccine. Measles, mumps, and rubella. We'll talk about mumps and rubella in a moment too. But globally, these stats are impressive. The 2021 data on the number of measles cases globally was sitting at around 9.5 million cases. In the US, we had a bad year in 2019. That was considered to be a pretty horrible year where we had over 1,000 cases. Huge spike. But if you compare that to the global data, it sort of tells a story again of how effective that vaccine is. And this graph at the bottom, I'm sorry that's so small, but the dates on here, the vaccine for measles was first introduced in the 60s. And you can see the number of cases was around 500,000, a little bit more than 500,000 cases annually. And that dropped off to somewhere in the hundreds after that vaccine was introduced. So very, very important. Talking a little bit about how unusual this last year was. This was the clinical picture a year ago in the United States, 2024, the map on the left there. We had some notable outbreaks in Illinois and Minnesota, and some refugee camps up there. So that was concerning, but there are usually a number of small outbreaks of measles every year. Last year we had about 285 total. And then on this larger map at the bottom there, you can kind of see from 2.5 years ago, January 2023, the number of cases we had during that entire year of measles was pretty low, very, very low. And then last year that spiked because of that major outbreak, possibly related in Minnesota and Illinois. So that was 2024, and then this year, early on, I think starting around January, we started seeing cases of measles out in West Texas and Lubbock and those other places. And there was pretty good sustained transmission in pockets of vulnerable people who were not vaccinated, so didn't have sufficient herd immunity. A lot of children were in this affected population. And this is the map that was pulled from this year, where our case number is over 1,300 now. As of now, I just pulled this, so this is very, very, very current. You can see Texas is definitely the state with the most cases of measles this year. So we'll see what this looks like in 2026 next year, if we're establishing a trend in terms of, or if we're seeing a trend in terms of vaccine hesitancy and things like that. But this is very concerning. We haven't seen this bad of a year for measles since 1992. This is a 3-decade high for us. Vaccine, measles, mumps, rubella, is a trivalent live attenuated virus vaccine. The vaccination schedule starts around a year, and then at age 4 and 6, and definitely before joining high school. So, efficiency 95% lifelong immunization with a single dose of this vaccine. The second target in the MMR vaccine, measles, mumps, rubella, is the mumps virus. This is another paromyxin virus, like similar to measles, negative sense RNA, unsegmented virus. This is unusual in that it affects primarily the salivary glands, and that contributes to this characteristic symptom that you can see in this child who has mumps. It's called parotitis. You have swelling of the salivary glands. It too is spread just like measles. It's not as infectious, but respiratory droplets, inhaling these respiratory droplets. Typically, after those kind of initial vague early symptoms, you can get this very distinctive parotitis presentation that you see in this child, but there are some other organs that can be affected that are concerning. The reproductive organs in particular, where if you get infections of the testes or chitis, for example, you can have some really serious problems like sterility, other tissues as well, ovarian infections, breast tissue infections, pancreatitis. This too can cause meningitis and encephalitis and deafness. So all of those complications add to the impetus to get people vaccinated for mumps. Let's see if I have data as to how many cases we have currently. So before we started vaccinating in the 60s, we had about 186,000 cases of mumps in the US per year. After that, we've had about 99% reduction in mumps cases. So, yeah. And then the last target for the MMR vaccine is rubella virus, also known as German measles. This is another one of the common childhood xanthan rashes. Pretty mild disease most of the time, just causes a rash, maybe a mild low-grade fever, sore throat. The rash presentation and the spread is not unique or distinctive. It starts on the face and then spreads downwards towards the rest of the body. And it's just kind of like a normal maculopapular rash that you can see on this infant on the top there. There is particular concern or unique concern with rubella virus because of its ability to be transmitted during pregnancy from mother to child. If that does happen, there are some birth defects and risk of miscarriage that are concerning. So that's one of the more serious concerns about rubella, but by and large, not a super severe virus for normal people who get it. We've had almost no cases in the last 20 or 30 years. We've had a total of 10 cases since 2004 in this country. It's extremely rare in the United States these days. Another one of the childhood rashes is caused by a completely different virus. It's not in the same family, it's not a coronavirus. This is parvovirus, B19. It's its own viral family. It's kind of one of those weird, funky outliers, single-stranded virus. So there is no vaccine for this one. It is pretty common. Transmitted through respiratory secretions, blood and blood products, and transplacental transmission as well. Has a very characteristic rash that presents on the cheeks, but it can spread through a lot of the other parts of the body as well. When you get the rash on the cheeks, which is usually the first indication that you have fifth disease, it has that characteristic slapped child look, spidery, super red rash that appears on the cheeks. And then you can get some other symptoms. They're usually pretty mild. This should resolve on its own, especially for children without too many complications associated with it. For adults, it's possible to get a rash, but the main problem with adults who get infected with parvovirus B19 is this arthritis. You get polyarthritis. It can affect a lot of different organs across the body. There's also problems with pregnant individuals who can also suffer miscarriages and stillbirths and cause anemia in the fetus, the developing fetus. The presentation itself, since this is common and since we can't vaccinate against, a lot of kids present, and because of that characteristic rash on the cheeks, we can usually make clinical diagnosis just based on the presentation itself. We also have immunoassays and PCR to diagnose this clinically as well. For the vaccine, if you are a dog owner or a cat owner, you probably have vaccinated your animals against parvovirus infections. So, I forget the diseases associated with cats and dogs, the presentation they get, but at least they do have a vaccine to protect them against parvovirus. Another wart-type virus. This one is caused by Molluscum contagiosum virus, a double-stranded DNA virus. So when we're talking about HPV, the genome of HPV was also double-stranded DNA, but the warts themselves have a different characteristic and different appearance from Molluscum contagiosum virus. Also different with this virus, with MCV, is the fact that this is a benign virus. It's not going to be an oncogenic situation. You don't have high-risk types of MCV. It's contracted by much a similar way as HPV, though. So this virus is in the skin. You get it when you have your skin coming into contact with someone else, and you have a break in your skin. The virus gets in from theirs to yours. So activities that are oftentimes implicated in these water warts, things like wrestling, sexual contact, and then you can also inoculate yourself. So if you have water warts and you're touching yourself, you can get auto-inoculation. The warts themselves are usually not painful. They might be a little bit itchy, but oftentimes painless. I should have commented when I was talking about HPV and regular like plantar warts. Those can be a little bit painful if you've ever had those before, particularly if they're on a weight-bearing part of your foot and you're stepping on them all the time. Just from the pressure of those warts. But with these, generally, I think you get them oftentimes like on the face and on the hands where you'd be touching other people. The diagnosis for this, I've never seen this on a lab order, so I think most of the time physicians are diagnosing people with MCV based on just the presentation and the appearance of the warts themselves. I'm not sure what they do for treatment with MCV, but like I said, it's benign, so maybe nothing. These will eventually resolve on their own within a year, typically, just spontaneously, they'll go away. Okay, smallpox. So, sort of rounding out this deck with these orthopox viruses, big double-stranded DNA viruses, among the biggest clinically relevant viruses, 200 nanometers, that's a giant virus. With smallpox proper, which we no longer have circulating, that is called variola major, which has a really severe presentation associated with it, with the higher mortality rates. There's also variola minor smallpox as well, which is associated with less severe disease. The disease itself has been eradicated for well over 40 years now, going on 45 years. The last case was in Somalia in 1977. Probably heard about its historical significance over the last few centuries. It's being responsible for killing countless people, influencing the course of history, et cetera, huge impact on developing civilizations. Something you should definitely read about if you have time. But in terms of our ability to eradicate this virus, this was like a crown achievement for public health. We've never been able to eradicate another infectious disease. Hopefully we can in the future. There's some pathogens that we have targeted for eradication, but it is extremely difficult to do this, so that was a major, major accomplishment. The reasons that we were able to eradicate smallpox is because it's only a human virus, there's no animal reservoir, so that makes it much easier. We had a good vaccine for smallpox, which we'll talk about. We also had galvanized public support, which, as we all know, is always the case, right? We always have public support for vaccines. So, but for smallpox, because it was stigmatized, a lot of people were more than happy to be vaccinated against this particular virus. Also, since it's a DNA virus, it doesn't mutate a lot compared to RNA viruses, so it was antigenically stable. We didn't have a lot of breakout strains that we had to control, as is the case with other viruses. Yeah, I'll talk about the vaccine in a couple slides. In terms of the presentation, though, this too is very infectious, super infectious virus. They spread through aerosolized droplets in the air that linger for a long period of time. That's the primary route of transmission, but the scabs and the vesicles that you get with smallpox can also contain a lot of virus as well. So as you're just moving around, those vesicles and pustules will spread virus as well. The progression of this rash, if you will, for smallpox virus is distinct if you compare it to another virus like chickenpox. So if you look at this figure at the bottom, you can see on the left bottom the beginning of chickenpox on day 2, on day 5, and then on day 10. This is considered to be an asynchronous progression where you see crops of these vesicles in different stages. So with smallpox on the top here, a patient with smallpox in day 2, day 5, day 10, it's a synchronous progression. It progresses from an early flat rash to macropapular rash to full papules to vesicles that have a little bit of fluid in them. Those vesicles become pussy, so they have that's when they start becoming a little bit painful and itchy for people. And then those pustules will eventually scab over, but that progresses from step to step with smallpox, unlike with varicella zoster chickenpox. So as that rash is progressing, it has a centrifugal distribution that we've kind of talked about before, so starting kind of on the face and on the trunk, and then it spreads slowly to the outer extremities over the course of a week or 2, and it will continue to spread over the entire body. The rash itself can be extensive. We'll see that in the next slide, how extensive that can be. In terms of contributing factors to this 30% mortality, these are major considerations for complications. A lot of the deaths due to smallpox are due to secondary bacterial infections, pneumonia cases, encephalitis, ocular complications, maybe not so much for death, but certainly with blindness. And then the multi-organ damage that can happen and the immune dysregulation that happens with smallpox cases. For lab workup, this is actually still a target on one of the BioFire, like the Warrior panel, I think, that has a lot of biological warfare agents on it. It's on there as a target now, 45 years after eradication, should this virus ever be taken out of stores and weaponized again. It's the same reason that most of us get vaccinated against smallpox, whereas the general population no longer does, just in case that virus is ever brought out of stocks again and weaponized. Where it is now today, we do have 2 facilities globally who maintain stocks of smallpox. One is the CDC, and the other is a lab called Vector in Russia. There's a lot of controversy about whether or not those smallpox stocks should be destroyed, but the rationale is we'd like to keep them around for research purposes. In terms of who gets the vaccine today, I don't know what year we stopped vaccinating the population, but the public writ large is unvaccinated now. So if you were born after a certain date, no longer, like I think around the early 80s, we stopped vaccinating the general population against smallpox. So most of the population is vulnerable. Lab workers will get the vaccine, military will get the vaccine, first responders, they get the smallpox vaccine. And if you've been vaccinated, you had a front row seat to kind of watch this progression of the rash and get to watch the entire thing as it all the way until it scabs over and kind of falls off. I said I would show a picture of a more severe presentation. This child was not vaccinated, this one was vaccinated, the boy on the right was vaccinated. And I don't know, I assume they're brothers, but you can see how dramatic that presentation is in the child who has smallpox on the left. I mentioned the PCR that we can test for. We also have, it's not hard to diagnose, fluorescent antibody tests are available. And the differential diagnosis, these days would be, I don't want to use the word ridiculous, but since it's been eradicated, it would not be high on differential. If you have a patient presenting with a rash, it would be extremely unlikely that it's smallpox. However, knowing the differences in the presentation between chickenpox and smallpox is still good to have in your head. Oh, other pox viruses. It's not just smallpox. We have Vaccinia virus, which is the same virus that we use to vaccinate ourselves. It provides cross protection against variola major. So Vaccinia virus on this list of other orthopox viruses can cause a mild disease. We also have cowpox, which is the virus that Edward Jenner used to vaccinate that little boy against smallpox. It's also presents as a milder form of smallpox that used to be used as a vaccine, early vaccine. Camelpox, as the name suggests, there's a bunch of different pox viruses that circulate in animal reservoirs and can be transmitted to people. But the most famous and the one that you guys need to know about, of course, is the virus formerly known as monkeypox. It's been retitled, renamed to Mpox because of the stigma with monkeys, I guess, I don't know, but don't call it monkeypox anymore, it's Mpox. There are 2 different clades of Mpox. Both of them are African clades. Clade 1 is the basin. It is the more virulent of the 2 clades, clade 1. Clade 2 is the West African clade. That is, results in a milder form of the disease, but that's the one that circulated in that big outbreak 3 years ago, 2022 Mpox outbreak. So that's what we're seeing on this bar graph on the right. We had sustained human-human transmission that really peaked. This is a global outbreak. It infected a lot of people, and just by scale, you can see the hundreds of cases that globally happen in a normal year. So normally, this would be something that we would hardly talk about. I learned about it first when I was doing a clinical rotation at Marshfield in Wisconsin. The doc who was training us had been one of the initial people to recognize an outbreak that we had in Wisconsin of this rare exotic African disease. It was imported by a pet distributor who imported some giant Gambian rats out of Texas. And the Texas distributor sold them to some pet stores up in Wisconsin and Illinois and Minnesota. And these giant Gambian rats were mixing with some prairie dogs at the same pet store. Prairie dogs contracted Mpox, and then were sold to some children, and the prairie dogs bit the children, and the children got monkeypox, basically. It's a little bit convoluted, but this doc was super interesting, and he kind of made his career the fact that he described this outbreak of Mpox that we got in Wisconsin in the upper Midwest about 20 years ago now. So when I was early thinking about Mpox, that's how I associated with transmission as a zoonosis from these animals who carry this virus. But like I said, with this 2022 outbreak, that changed the way we think about this virus. There are a lot more ways to transmit it, and there are more efficient ways to transmit it, even person to person. Probably the best way to transmit it, as you get these vesicles that look like this, we'll come back to this screen in a second, but you get these vesicles like other pox viruses, especially if they break. That fluid is packed with virus, and you can transmit it very easily person to person that way. We also had a deeper appreciation for the transmission, sexual transmission of Mpox, particularly with the MSM community again, the homosexual male community. A lot of these cases in that 2022 outbreak affect that population, which I don't think previously was well appreciated. So we've got direct contact, we've got sexual contact, respiratory droplets, you can inhale this, exhale it, inhale it. Contact with the infected animals themselves, like I mentioned, and then even contaminated clothes can have enough virus on it to cause transmission. We do have a vaccine. It's not, I don't know how well it's stockpiled or scaled up right now, but after the 2022 outbreak, we tried to scale up our vaccine source against Mpox. But we still rely a lot on making sure we educate people about how it's transmitted and identifying early signs and symptoms of Mpox and potential exposures. In terms of the rash itself, it is a painful rash, particularly once it gets to, so we have the first stage, macropapular, and the second stage where you start getting a little fluid in those papules. And then by the time you get to this stage, this third panel there, that pustular stage, then they become painful, and they become itchy, and they become a nuisance. At that fourth stage in this panel, this is when they crust it over and become scabbed. So this is also kind of like a synchronous progression of rashes. However, when it ripped through that many people during the 2022 outbreak, we also saw a fair number of asynchronous rashes, so that upset the reliability of that pattern a little bit. Other symptoms, swollen lymph nodes, chills, exhaustion, muscle aches. The rash usually originates at the point of entry, so if you get a sexual transmission in the genital region, etc., or if you get a bite, it's around where you got the bite. Rashes will spread, once it starts beginning, it'll start developing and they're spreading outwards within 1 to 3 days. And the illness is self-resolving, so within 2 to 4 weeks, it should mostly go away. I don't think there's any specific treatments for Mpox. They're mostly supportive. We do probably have some good specific PCRs now, but previously our PCR positives were inferred if they were orthopox positive but variola negative. So they were ruling out smallpox, but it was an orthopox. Sorry, I want to see if I can dig up one piece of information. I can't put it in here. Oh, sorry, yes, here it is. The number of cases we had. We had 30,000 cases of Mpox in the United States during that outbreak. So, huge number of people here. And it was global, so a lot of countries had Mpox cases. That is it, guys. Any questions about virology? Okay, I'll see you guys tomorrow, at whatever time I'll reschedule, but we'll start the oncology lecture tomorrow. That's just a one-day lecture. Thank you.